السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وعلى آله وصحبه أجمعين. Hello everyone and welcome. My name is Muad al-Musallam and I'll be your host and moderator for today's webinar. Thank you all for coming and taking the time to join us today as we talk about an interesting topic, an introduction to vestibular system rehabilitation, which is an emerging topic in physical therapy and rehabilitation, where patients with balance issues and dizziness may need your assessment and intervention. So hopefully you will leave from today's session with a better understanding of what vestibular system rehabilitation is and how you can effectively apply it with your patients in a clinical setting. And to make sure we are helping you as best as we can during this session, we have a chat box for questions. So please feel free to drop your questions on the topic or share your struggles and experiences. We'll be glad to answer your questions at the end of the session or at the end of the webinar. Also, don't worry about making notes since we will be posting the session's recordings on the PT Club YouTube channel. So please make sure you subscribe to our channel to receive notifications when we upload the recording of this session. Lastly, there will be a feedback survey posted by the end of this session to get to know your feedback. So please make sure to fill out the survey in order to ensure to receive your certificates. And in order to receive your certificates with the correct name, please change your Zoom username to exactly the name you want it to appear in your certificates. Please use your first name, middle name, and family name. So without further ado, let me introduce to you our talented and experienced guest speaker, Dr. Faiz al-Mubarak. Dr. Faiz Mubarak is a physical therapy consultant working in Abha. His interest and expertise lies in vestibular system rehabilitation. He's also a certified practitioner in several manual therapy approaches for musculoskeletal and orthopedic conditions. Welcome, Dr. Faisal. We are thrilled to have you today with us. Thank you for accepting our invitation. And certainly we hope that today's webinar turns out to be a fruitful learning experience for all our needs. The mic is yours, Dr. Faisal.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, my friend, Dr. Muad. It's a pleasure, wallahi, being here. It's an honor that I give this lecture, being moderated by you and attended by my colleagues. And I don't know, should I call it Khobar or Dammam?
Eastern Province.
Eastern Province.
No, the honor is ours, Dr. Faisal. Always a pleasure. Actually, when I was told you were going to give this lecture, I wanted to be the moderator for this. So thank you. It's an honor.
Thank you so much. Allah yasadik habibi. طبعا, thank you so much, guys. Thank you for having me. At the end, Muad said that there is a feedback, so please, guys, make sure that you give a good feedback about me. I'll try to do my best, inshallah. طبعا, Bismillah ar-Rahman ar-Rahim. My name is Faisal al-Mubarak. I'm a PT practitioner. Our today topic will be discussing the vestibular rehabilitation. I'm sure that most of you have been through any materials of vestibular rehabilitation, either theory or practice, or maybe even experiencing that by yourself or by any member of your family or any friend. But before we go through this vestibular problem, I would like to go first to discuss why we're looking at the vestibular disorders, or why would you look at the vestibular system because at the end we are dealing with the whole body. Okay, so I want you really to forget for a moment about the vestibular system and ask yourself this question: why would I be interested to know more about vestibular? It's the same thing that you do when you look at any other system, for example, as a rehab therapist, I would say either PT, OT, whatever your specialty is in rehab, you are looking at how can you make this person independent again. How can you work hard in developing or enhancing the quality of life of this person? So here we are looking at the functionality of the body. And one main thing of body functionality is laying on the balance system. So patient or any person who is having difficulty in maintaining their balance, their quality of life is affected. They cannot function. They cannot do anything. They will be disabled. So, so balance is the main thing that we're talking about today here. And so when you look at the balance as a whole, okay, when you look at the balance as a whole, you find out that there are many factors that you need to look for. One of these factors is the vestibular system. So what I want you to know is when you have a patient coming to you in the clinic, you're not going to only look at this patient's vestibular system. You will be looking at all aspects of the balance system because you want to make sure that your patient is leaving your clinic having a good balance. All right. One of the professors said one time that when you are in the clinic, you're gonna have an ear coming to you by itself. You will have a whole body, a whole person, whole human coming to you, complaining or discussing with you any of their balance issue. Right. So now let's see that, or let's say that we have a quality of life that we need to look for, and we have a fall, okay, that we have to avoid. And why would you think, guys, we need to avoid fall? Right? Can I have, I don't know, Matt, if participation is allowed? So I would like to have a one or two people answering that question. How would you guys think that fall is harming is harming the human nature? Let's have let's have one person or two. Just open the mic and talk. Alright. معاذ ما أدري إذا كانوا يقدرون يشاركون الزملاء.
We currently disabled the mic, but I think we can manage it. Just give me a second, Doctor.
Okay, no, don't worry. It's not a big deal. I just wanted to have people to interact. If it's easy.
I think it's just through chat only. The mics are disabled.
طيب يلا خلونا نشوف الشات.
Yeah.
Okay, fracture might lead to injuries. Fall main cause of death. I love that. Who said that? سارة العتيبي. Thank you, Sarah. طيب true يعني many injuries are might be caused by this fall, but death is one of the main thing here. As you guys can see, the World Health Organization, WHO, has stated that the first leading of unintentional death يعني الوفاة الغير متعمدة على مستوى العالم رقم واحد هي حوادث السيارات. فتخيلوا كم واحد عندنا يموت من حوادث السيارات في العالم. The second leading cause of unintentional death just right after the road traffic accident is fall. So we're talking here about a big and huge number of people dying in the whole world because of death, because of fall. So, here is other data that you guys can see, sharing that there are many other injuries that can be happening to these patients beside death. So we're talking about a serious problem here. Okay. طيب خلوني اشرح لكم هذه الصورة. اوكي. هذه الصورة اذا انتم شايفينها معايا هنا في السكرين. طيب تتحدث عن ايش؟ عن البالانس. كيف احنا نشرح. I'm sorry, I'm trying to minimize my thing here. Okay, worked. الحمد لله. طيب I'm sorry. اوكي. طيب الان يا جماعه احنا لو نشوف السكرين هذه قدامنا، شايفين البالانس في الاخير. الان احنا كيف نضمن انه الشخص هذا او how can we make sure that this patient is or this person is being balanced. Okay. طيب we have 3 steps here. We have a sensory input, we have an integration of input, and we have a motor output. طيب خلونا نبدأها, or let's start with the sensory input. Now the human body have receptors. Okay, so any information or anything coming from outside the body is being received by the body in different ways. Okay, so in here we're talking about vision, vestibular system, and somatosensory sensation, proprioception. Okay, so now if I'm standing or if I'm sitting right now, if I go down or if I move down, I can see by my vision, I can see that I'm moving. Okay, I'm turning my head. I can see I'm being, or my brain is being oriented by the vision that we are moving here around in this area. Okay, same thing is happening with the somatosensory sensation. Now, if I'm standing and I'm laying down, or I'm sorry, I'm swaying, you know, by my ankle joint or by my knee joint or by my hip joint or by all other kind of muscles in my body, I can feel that my body is moving. Okay, by my proprioception sensation. Okay, now if I close my eye and I want to bend my knee and extend it again, how would I know that I'm bending and extending without looking at the eye? Is that by the feeling I have here, the proprioception sensation. Also, the vestibular system is smart in detecting that too. So the vestibular system can detect this motion of the body. Okay, so and we'll talk later about how would this system, the vestibular system, how would this system detecting this motion. Right? What I want you to know now is that we have a 3 sensory input: the vision, proprioception, and vestibular system. And the second information I want you to know is that all these inputs are going to the brain. Okay? And when these inputs are going to the brain, all of these has to be or have to be matched together. So you can't have a different information. Okay, and if you have a mismatch of this information in 1 or 2 of them, then you have a problem having an imbalance when you have a mismatch of information going to the brain. طيب. So let me give this example. Now, if I look straight, if I'm looking straight now, neutral position, طيب, and I turn 45 degrees, or I was asked to move my neck 45 degrees to the right. Okay, so in this motion, the vision has told the brain that Faisal has moved his head for 45 degrees. And how did the vision say that? Because the eye looked and saw the motion started and then going and then stopped. So the vision was telling the brain that Faisal is moving, right? The proprioception feeling or sensation that I have in the neck and the butt and the cervical vertebrae, when they move, they're sending signals to the brain telling that Faisal is moving. And Faisal started motion and Faisal stopped motion. Okay? Lastly, the vestibular system, and you will learn this when we are discussing the physiology of it. The vestibular system has the ability to also tell the brain that Faisal started the motion and stopped the motion. Okay, so all these three information are going to the brain, and all of this information, as we said, has to be matched. Right? When it's in the brain, it's been integrated in the brain with other information to come out as an output. Now, when we're talking about motor outputs, we have different kind of outputs, but we will be focusing into two outputs. طيب. The first output, what we call the the VOR, which is the vestibulo-ocular reflex. Vestibulo-ocular reflex. The second one is the VSR, which what we call the vestibulo-spinal reflex, right? So we have a vestibulo-ocular reflex, and we have the vestibulo-spinal reflex, VOR and VSR, right? What are the difference between these two reflexes? The first one, the VOR, is actually the relationship between the eye motion and the head motion. طيب. Now, if I am, يلا خلونا ناخذ this example. If I am driving a car, okay, and my head is moving, طيب, because you know I have an uneven road that I'm driving in, طيب. So, do you guys think that my eye is moving or not moving? يلا خلينا نشوف. Do you guys think that my eye is moving or not moving? Oh, look at the chat. Moving, moving. Yes, yes, moving, not moving, not moving, not moving. It's moving, moving, not fixed. Okay. طيب في كذا بين وبين تمام؟ طيب actually the eye is moving. طيب يعني الحين أنا لما أجي كذا أمشي في طريق وعر مثلا ولا طريق ترابي and my head is moving, the eye is moving too. لكن the eye is moving, ركزوا معي في هذه. The same speed of the head motion, تمام? The same angle of the head motion, but different direction. تمام؟ يعني لما تتحرك معي، لما يتحرك راسي يمين يسار فوق تحت، العين تتحرك نفس السرعة، نفس الزاوية، ولكن عكس الاتجاه. إذا راح راسي يمين عين تروح يسار، إذا راح يسار عين تروح يمين. ليش الهدف هذا كله؟ من عشان إيش؟ عشان what we call gaze stability. VOR is important to maintain the gaze stabilization of my gaze، اللي هي الحداقة، إني أركز أنا في الشيء. مثلا أنا راكب مع الشخص نفسه اللي قاعد يسوق والسيارة تتحرك، لكن أنا أقدر أستطيع إني أقرأ رسالة في جوالي أو أقدر أستطيع إني أقرأ الكتاب. ليش؟ لأني مركز. تمام؟ فالability هذه it's given by the VOR who can maintain our gaze or stabilizing our gaze. And if we have an issue in this reflex, you won't be able to stabilize your gaze. And even if you try to stabilize your gaze, you would feel dizzy, you would feel uncomfortable, nauseous, and just you want to close your eyes and rest for a while. طيب. The other thing, or the other output, is the VSR. I'm sorry, the VSR. So the VSR is the vestibulospinal reflex. And the vestibulospinal reflex basically is the ability of our muscles to maintain extension so the body posture can be maintained. طيب. يعني الآن عندنا احنا لما نكون واقفين احنا we have to assure having ايش اللي هو البادي الposture الثبات. تمام. How can we maintain this posture by ايش by assuring that our muscles extended. صح. If I don't have the ability to extend my muscle, what would it happen? I would fall down. صح. That's why we have the VSR, because it helps us maintain our extension so we can maintain our body posture. طيب. I'm sorry I spent a lot of time in this slide, but this is very important slide. If you understand this, things are gonna be much easier for you dealing with balance. صح؟ لأنه إحنا we are like if proprioception is mainly can be affected by musculoskeletal system. صح ولا لا؟ إحنا الآن this is like an equation. This is like an equation of balance. So the result is balance, but this is the equation. So you have to make sure that all factors are here to get the right results. طيب. عندنا هنا خلونا نقول for example if I have a hypofunctionality or an issue in the functionality of the vision, either I help this patient regain their functionality in looking at things. تمام. If I can't, I would substitute and train the brain to rely on the vestibular system and proprioception, not more on the visual system. طيب. If I have an issue with the proprioception sensation, if I have an issue in the functionality, if I can regain it, I would regain it by enhancing the proprioception sensations as we do with exercises and things like that. But if I have a person with a sensory loss and they have no sensory or no proprioception sensation anymore, what would I do? I would let the brain to be substituted and try to rely only on the vision and the vestibular system. And the same thing, if I have an issue with the vestibular functionality, I can either enhance the functionality of the vestibular system, and we will learn this inshallah, or if this a loss, so no more vestibular system, I can have the patient to be substituted and trained to rely only on the vision and proprioception. Do you have any question, guys, so far? طيب, and I will leave the question. Maybe now after كذا 10 minutes ممكن we have a question, then we move. طيب. الآن very quick moving or going to the some definitions here. We guys know center of gravity, I'm sure, and you guys know base of support, and you guys I'm not sure if you know limit of stability, but limit of stability is the limit where you can sway before either you fall down or you take a step forward. Okay, so that's the limit of your stability. A very important thing to know also when you are dealing with balance impaired patients, that there is something that we call standard cane, a quad cane, a walker frame, and a belt. And this gait belt is for your safety as a practitioner and the patient safety. It's not only helping to transfer, it's also, and the main thing here is helping the patient to be safe and the practitioner as well to be safe. So here, as you guys see in the picture, you don't have actually to put it in yourself as a practitioner, but you put it in the patient waist, and you don't make it very tight and you don't make it very loose. You just make it in a way where you can have your fingers in between. So in case you need an assistance to give to that patient, you can give. طيب. Here are some muscles that are actively working when patient or when person is standing. So these are very good information to know, because sometimes having weak muscles in one of these muscles, it can affect your patient support. But is this, or are these the only muscles working when we have a patient standing? No, but these are the major one working, but we have other muscles that are supporting. Like if I go down the stairs, can I say that I'm not using my neck muscles? No, I'm using my neck muscle to support my neck. صح؟ ما أخليها تطيح. But we don't say it. Okay, so these are the major muscles that are working, and when person is standing. Now the strategies here we have an ankle strategy, where you, like, if you are standing and someone is giving you a little push, okay, you can maintain this push not falling by using your ankle. But if this push is harder, then you might be using your hip strategy to avoid falling. Right? Maybe this push can be even harder, then you have to do a step forward, so what we call a stepping strategy to avoid falling. And the reaching strategy is when you are trying to reach something. Right? Some grades here are important to use when you are testing or seeing the patient. So there are 5 levels, right? And it are very simple to memorize, from 0 to 4. Okay, so absent from bottom. Let's start from bottom. Okay, or let's start from the top. So normal and good, both of them are when you are testing patient with no cane. So if someone coming to you with no assistive device, so you keep in mind that they are either 4 or 3. And I will tell you now what's the difference between 4 or 3, okay? But if someone coming to you and using an assistive device, then you keep in mind that they are either between 2 and 1, okay? And if someone coming to you in a wheelchair and can't move at all, you just put it in number 0, which is absent, right? So let's go back to the top. So 4 is someone that is not using the assistive device, okay, but they can travel or they can walk from point A to point B, and at the same time, they can pick anything from the floor and continue walking without having their balance affected, right? 3 is when you have someone who can even walk from A to B without using an assistive device. However, they are not able, or they find very difficult to go down and pick something from the floor and continue walking. So they can't, but they can still walk without an assistive device. And they can walk by looking right and left, but they cannot, while they're walking, they cannot pick. It's difficult for them, it's challenging for them to pick something from the floor and continue walking. طيب. 2 and 1, the difference between them is 2, you are using an assistive device, but they need a minimum assistance, okay? Like they walk next to the wall. They don't support by the wall, but they are walking next to it in case, just in case they need, okay? However, 1 is when you have an assistive device and you really need to have someone else next to you to hold. So you have an assistive device and you have someone next to you to hold. So you have either you have maximum assistance that you need. طيب. All right, before we move on to this section, Muad, can we see if we have any question to answer? even for me كده to get a break كده اخذ لي coffee.
Yes, there's a question that says any specific distance for assessment regarding the previous slide.
Again.
Regarding the previous slide about balance and function of balance, the grades, is there any specific distance for assessment? Is it based on distance or just the ability to do the balance test only?
Yeah, it's well, just the ability to do this balance. Yani this motion. Usually we put it 10 feet, not more than 10 feet.
10 feet.
But actually, 10 feet, 3 meters. And this is usually what we do.
The second question is, what's the relationship between balance and vertigo?
Oh, there are relationship between vertigo and balance. Well, vertigo can affect your balance. That's how it's differ from each other. So vertigo, well, balance is a functionality, and vertigo is a symptom or a sign that you have, or a symptom. So if you are, or if you have a vertigo, your balance is affected.
Okay. Just can you repeat also explaining the grades again, because there are some questions regarding grade 3 and 4, and someone also said grade 1. So if you can just go back on the same slide.
Okay, let's say it again. Now we have four. We have four. Oh, I'm sorry, 5 grades here. Okay, so I want you to look at it as and put it into 3 sections. 4 and 3 in one section, 2 and 1 in one section, 0 in one section. Right? 4 and 3, that when the patient is moving from point A to point B without assistive device. So if you have a patient can walk without an assistive device, so either you put them in 4 and 3. So you put them in 4 when they are going from A to B without with the ability to pick something from the floor. So I can walk and pick something from the floor and continue walking. However, if the patient finds it challenging to pick something from the floor and continue walking, that means that this patient into 3. Okay, 2 and 1 is when the patient is using assistive device. But fair is when I have this patient using the assistive device, but they don't want another thing to use it. They don't want to be supported in the wall, in the rail. They don't need to be supported by another person. They're fine. They're just fine using this cane, and they might be just walking next to the wall just in case. Poor, or number 1, is when the person is using a cane and they need to be supported by someone or next to the wall. Okay. 0 is when the patient having 0 balance, like they are relying on the wheelchair, so they cannot actually move without a wheelchair. Right? Here now we have a lot of balance testing or balance examination. Right? The American Physical Therapy Association have developed, at the neuro section, have developed an outcome measures. Okay, so these outcome measures has been tested by this section, the neuro section, and they call it evidence database to guide effectiveness, the EDGE, or vestibular evidence database to guide effectiveness, which is the VEDGE. So here, what they did is they brought all outcome measures of the balance examination, and they tried to see how effective are they. And they rank it between 4, which is highly recommended, 3, which is recommended, 2, which is reasonable to recommend at this time, 1, which is not recommended. طيب, I selected some of them here for you to take a look at it. So the first one is the activities specific balance confidence scale, what we call ABC. ABC is from 2 to 3. It's a very nice test, a very important test to use. But what are we doing here? What are we testing? We're testing the patient's confidence level, right? Because we really want our patient to be confident. Or our patient, our dizzy patient, our balance impaired patient, when they come to you in the clinic, their confidence level is decreasing. Why? Because they are not confident anymore to do such a movement because they are afraid to fall. Okay, so they are not confident. So this is one thing that you have to measure, and this is something that you have to work on. طيب. The 4-step square test is a dynamic test, and they rank it 3, which is recommended. Functional reach test ranked as 2, which is reasonable to recommend at this time. Modified clinical test for sensory interaction, which is what we call modified SETSIP or modified CATSIP, is a static balance and is ranked as 2, which is reasonable to recommend at this time. The functional gait assessment is one of my best assessment ever that I use, actually. It's ranked from 2 to 4. Time up and go is ranked as 2. I know that there are, these are a lot of examination, and you guys would really like to know each specific one, how is it done, and how is it being instructed, but the time is running, and we really want to go through different items here. But first of all, I can send a copy of this presentation to Mu'ad, and he can spit it out to you guys. Also, I can, you guys can go and Google these tests. It's easy to find, like at YouTube, and you can see people explain it to you in details. Okay, it's very simple. So one more thing here that we're looking at is proprioception. طيب. So there are a lot of things can impair the proprioception system or functionality in our system, and there are different exercises that we can use to enhance. I mean, true, you have to fix the issue first, then you can start the exercises later on. Okay, now we're going to the thing that we are all here for today, which is the ear anatomy or the vestibular system. Looking at the ear anatomy, there are 3 parts of the ear. There is the outer ear, and there is the middle ear, and there is the inner ear here. Okay, so the inner ear here is combined or include the cochlea, which is the auditory system, and the vestibular system, which is looking at the balance system. طيب. Now, if we zoom in to the inner ear itself, here we see the cochlea, which is again responsible for the auditory functionality. And we have here the vestibular system, the whole thing here, this whole thing here, starting from here and up. All this is the vestibular system. طيب. So we are focusing and looking at the vestibular system right now. طيب. Now let's look at the anatomy of the vestibular system. The anatomy of the vestibular system, let's do it this way. It's very simple anatomy, and I want you all to focus. All right, so if someone is now focusing here and there, okay, please focus now. Anatomy is very important, right? So the anatomy of the vestibular system, let's do it this way. Now, we have something we call semicircular canals, and we have something that we call otolith organs. طيب. Let's start with the semicircular canals. The semicircular canals, as what we see here, we have the anterior canal, this one, the whole thing, semicircular. They call it semicircular because it's not full circle. is half circle. Okay, semicircular canal زي عندكم في الشرقية في ليش الهاف مون صح؟ طيب شاطئ نصف القمر. ف semicircular canal. طيب the anterior one is this one, the posterior one is this one اللي تحت هذه posterior، اللي في النص هذه نسميها احنا ايش؟ lateral. Now in some books you will find this called maybe superior. So this is either you call it anterior or superior, and this is you can call it posterior or inferior. It's the same thing. And here you can call it lateral or horizontal. It's the same. طيب. So these are the three semicircular canal. So in each ear or in each vestibular system that is located in the inner ear, we have 3 semicircular canal, meaning that we have 6 semicircular canal in the whole body. طيب. Now, the otolith organs, which are 2 in each side, what are they? They are the auricle, the first one, and the saccule, the second one. Okay, so we have the auricle and we have the saccule right here. تمام? So we have 2 otolith organ in the right, we have 2 otolith organ in the left. So we have auricle saccule, auricle saccule. طيب. Now, before we move on with our anatomy, what are the functionality of two? طيب. Semicircular canal are responsible to detect the angular motion. So if the patient's head is moving into flexion or extension, this is angular motion. تمام؟ هذه is detected by the semicircular canal. The side bending is also an angular motion, so that is detected by the semicircular canal. The rotation motion is also an angular motion and is detected by the semicircular canal. Okay? So that's the job of the semicircular canals, to detect the angular motion, which is this, this, or this. Okay? Now, let's go to the otolith organ. So what are the job or what are the functionalities of the vestibular, or I'm sorry, the otolith organs? Now, the otolith organs can detect the linear motion. What do I mean by linear motion? I mean, if someone is going forward, backward, side to side, or the elevator motion up and down. So that's our linear motion. You're not actually doing any angular motion here. You are just walking forward, walking backward, walking side to side, or going up and down. So that's what we call the linear motion. And that is responsible, or the otolith organs are responsible on that or for that. Okay? So what I mean, few things here that I want to share with you in regard to the anatomy for the vestibular system. Now, if we look at the semicircular canal, at the semicircular canal, we have 2 canals inside each one. طيب. So we have this canal and we have another canal inside. So, and there are fluids inside. There are fluids inside. So here, the darker one here is what we call the perilymph. And the lighter one here is what we call the endolymph. Right? So we have the perilymph and the endolymph. Okay? Also, what we need to know in the semicircular canal, that they have an open end and a closed end. So it's like a straw. طيب زي المصاصة. Okay, there is an open end, ناحية مفتوحة، نهاية مفتوحة, or there is a closed end, نهاية مغلقة. تمام. So the closed end is closed by what? By something we call cupula. اللي بالأسود هذه, the thing in black is what we call cupula. طيب, we can see the swelling here. This we call ampulla. Okay, ampulla, inside the ampulla there is a cupula. So the cupula actually is closing that end. طيب, so what I want you to know here, that we have the canals, the semicircular canals, and there is a fluid inside these canals, and these canals are open from one side and closed from the other side. So as you see here, each canal is closed from each side. And close from here and open from here. Close from here and open from here. Close from here and open from here. تمام. طيب. Let's go to the physiology of the vestibular system. Before we move on to physiology, خلينا ناخذ كم سؤال يا معاذ.
Okay. Before I give you the questions, في تعليمات الله يعافيكم بخصوص تغيير الاسم. تقدر تغير اسم الموظف في الزوم عن طريق الضغط على النقاط اللي جنب الاسم. تمام. And look for rename. بعدين تقدر تغير الاسم لأن تراودت أسئلة كثيرة بهذا الخصوص. آسف دكتور فيصل.
لا تحت أمرك حبيبي.
يعطيك العافية. طيب في سؤال أتوقع يمكن من السلايدات السابقة. هل طنين الأذن له علاقة مع اختلال التوازن؟
ممكن في بعض الباثولوجيز تسبب اختلال في التوازن تسبب طنين أذن.
تمام. هل نتعامل مع مشكلة الاتزان الذي نجده عند الراشد بنفس الطريقة الذي عند الطفل؟ يعني adults compared to children.
لا يختلف، لأنه إحنا لما نتعامل مع الادلتس عادة نتعامل مع someone grown up، يعني كل الأعضاء اللي فيه ما شاء الله نمت وتحسن، بس إحنا لما نتعامل مع pediatric generation we are dealing with someone who's growing. تمام. فتختلف في بعض ليش الاستراتيجيات في التعامل مع هذول المرضى مع هذا السن.
Two more questions or three more questions إذا تسمح يا دكتور.
عفوا عليك.
Should we assess balance strategies without assistive devices?
No, if a patient using an assistive device, you cannot let this patient be tested without this assistive device because it's part of his life now. خلاص.
Okay. The next question is, how do you grade if you're using an assistive device if it's a standard cane, a quad cane, or a walker frame? Because those assistive devices have different level of stability.
You can still grade it as we said. طيب, يعني you can see, because you can see if someone can actually use this assistive device without an assistant of someone. Okay. لأنه actually it is very different. Quad cane and single cane are almost the same. And I would say quad cane, I mean walker frame is actually, you know, to me I can see the walker frame is really, you know, has to be used with someone who know how to utilize it. So if the person can actually maintain the walker frame, I can put it in 3 because he's not using someone else to support him. Okay, I don't know if it's did I say 3 or 2? I think I said 3. 3. Yeah.
Should we continue with the questions or you want to continue?
Yeah. لا لا عادي. كم في باقي سؤال؟
والله زادت الأسئلة, which is good.
Yeah, of course.
Yeah. There's a question that says, what is the function of the fluid in the ear? Again,
no, we're coming to it now.
Okay, we're coming to it. Another question is, how are we able to differentiate dizziness from vertigo? How can we differentiate?
We'll come to it.
Okay. السؤال هنا, هل اللي عنده مشاكل في الأذن الوسطى يؤثر عليه في الشوارع المنحدرة؟
maybe because sometimes يعني يكون فيها what we call some inflammation or some infection happening to the middle ear, and these can affect actually the functionality of the inner ear and can cause a balance issue here. Yes.
Okay. Two more or three more questions, simple questions, inshallah. What's the function of the capula?
We'll get to it now.
We'll get to it. Okay.
Yeah.
Regarding to the ambula, what is it responsible for?
The ambula is actually a structure of a part of the structure of the canal, the last part of it, the closed area. It has inside the cupula. The main functionality there is for the cupula. That's what we will explain now in the physiology part. Inshallah.
Okay. The last question, what is the cause of dizziness after using the elevator? This is
depends.
Interesting. Yeah.
Yeah, it depends. يعني احنا when you are using the elevator, just being afraid from the elevator can cause you dizziness. تمام؟ And some psychiatry thing or some psychological thing can affect your balance. Maybe you are also experiencing an issue with the vestibular system that is affecting also your maybe some some other causes can cause this problem. So any patient actually complaining of dizziness or imbalance, we will be discussing now on how to go through these complaint and how to really assess them to know exactly under which category we should put these patients to. Right? So let's move to physiology, if you allow me. Right?
Sure.
Now if the physiology part of it is where we'll start by the. So now we have angular motion and a linear motion. As we said, the angular motion, the responsible for the angular motion is or are the semicircular canals, okay? And the responsible for the linear motion are the otolith organs. طيب. Let's start with the angular motion. Now, if you guys remember, just look at the picture here. If you remember what we call the semicircular canals, each canal has an open end and has a closed end. And inside these canals, there are two kinds of fluid, the perilymph and the endolymph. I want you to forget now about the perilymph. Just focus on the endolymph, which is the lighter in color, okay, here. So this canal or each canal are closed by the cupula at the end. طيب, the cupula at the end. So this cupula looks like this exactly. So there are hair cells in the cupula, and there are nerve fibers connected to these hair cells. So what's happening now? What's happening now, and how can the brain knows that there is a motion in the body using the vestibular system? طيب خلونا ناخذ example. طيب قبل ما اروح example هذا, I want to share with you one thing. Now, as we said that we have three semicircular canals and three semicircular canals here. طيب, before this semicircular canal, we have a vestibular system here in this ear, and we have another vestibular system here in this ear. طيب, these two systems are working together. طيب, so in one direction, one of the system will be activated and the other system will be inhibited, and vice versa. Okay, and why is that? It is because for the brain to know to which side the brain or the head or the body went. Right? I'll explain more. Now, we have three semicircular canals here and three semicircular canals here. Right? The horizontal canal or the lateral canal in the right and the horizontal horizontal canal and the right or the lateral canal in the left are responsible for the rotation motion. طيب. So, as you guys can see here, this lateral or horizontal canal right here. طيب. Now, if I'm asked to move my head to the right, like this. طيب. الآن the eye told the brain, صح؟ احنا قلنا الفيجن. في الفيجن told the brain that Faisal started the motion and stopped. Also, the somatosensory sensation and the proprioception here in the neck told the brain that Faisal initiated the motion and moving and stopped. How about the vestibular system? How does this work? طيب. The vestibular system, when I move to the right, what is happening here in the horizontal canal? In the horizontal canal, the fluid that we have in the canal is going toward toward the cupula. يصقع في الكبلة. يضغط على الكبلة. يدفع الكبلة. فيسوي لها what we call pushing the cupula. Push the cupula. طيب. فنلاحظ يصير هنا الهير سيلز هذه are getting into each other كذا ينضغطون على بعض. ليش؟ لانه السائل جاي عليهم كذا وضغط عليهم. طيب. فلما يضغط عليهم هذه يسمونها البوش. it's pushing. يدفع كذا pushing. تمام. فلما it's pushing في firing بيصير signals بتروح للبرين. هذا activation للجهة هذه. In the same time في نفس اللحظة بالضبط لما يصير في activation هنا، لأن أنا تحركت كذا صار في activation هنا، راح السائل جهة الكبلة. في الجهة الثانية السائل يذهب بعيدا عن الكبلة. It's getting away from the cupula. فإيش يصير؟ العكس. السائل يبتعد عن الكبلة فيسحب الشعيرات بعيدة كذا. تمام. إيش يصير؟ يصير pulling. يسحب pulling. في الجهة الثانية هناك صار pushing. يسحب يدفع. في الجهة الثانية صار pulling. يسحب. That's why احنا what we call this physiology we call it push and pull. We call it push and pull. طيب. لأنه في pushing قاعد يصير هنا وفي pulling قاعد يصير هنا. يعني لما طلعت أنا يمين صار في pushing هنا وصار في pulling هنا. لو طالع يسار يصير في pushing هنا ويصير في pulling هنا. فلما يصير في pushing ايش يصير؟ النير فايبرز هذه ترسل سيجنالز للبرين تقول هنا في activation، وفي نفس الوقت النير فايبرز في الجهة الثانية ترسل للبرين تقول هنا يصير في ايش؟ pulling، في inhibition. طيب. البرين يعرف برضه انه الفيستيبولار سيستم يعرف من الفيستيبولار سيستم انه فيصل تحرك وفيصل وقف. تمام. يعني انا طالع كذا الفيجن والفيستيبولار سيستم كلهم شغالين مع بعض. فيصل بدأ فيصل انتهى. كلهم يرسلون نفس المعلومات. اذا في اي واحد فيهم في مشكله او في خلل وقاعد يرسل معلومات غير يرسلونها الباقيين يصير في لخبطه في البرين ويصير في امبالانس وفي ديزنس. عشان كذا لازم نروح نشوف من هو سبب المشكله هذه ونعالجه. تمام. اللي ابغاكم تعرفونه هنا انه الفيستيبولار سيستم جهاز يشتغل الجهتين مع بعض. يعني الحين لما طالع انا نيوترال قاعد الاثنين شغالين فايرنج بس بنفس الليفل. بمجرد انه طالع يمين زياده يرتفع هذا وينزل هذا. يرجع نيوترال. طالع يسار يرتفع هذا وينزل هذا. نفس ما نتعامل مع الفيس مسلز. الفيس مسلز كلها مشدوده الحين مشدوده بشكل متساوي. لكن لا قدر الله لو صار في ضعف في احد الاعضاء هنا في الجزء هذا ايش يصير؟ لو ضعف هذا ايش يصير؟ الجزء اللي طبيعي يسحبه. تمام. لكن اذا هم شغالين كويس خلاص يصير كلهم متساويين. حلو. في الفايرنج ريت او ارسال المعلومات متساوي لما طالع نيوترال. اوكي. فهذه الانجلر موشن. انه كيف فيصل الحين لما اجي انا ابغى ادنك تحت يمين كذا بربط الشوز. انتم بكرامه شوزي في الرجل اليمين نازل بالحركه هذه. هنا فين يصير البوش وفين يصير البول؟ يصير البوش في الرايت انتيريور والبول يصير في الليفت بوستيريور. شوفوا كيف كذا. لكن اذا جيت انزل على الحركه الثانيه كذا يصير انتيريور هنا بوش والبوستيريور يصير بول. والعكس صحيح، يعني اذا جيت طالع فوق عكس، يصير هنا بوش وهنا بول، ولما طالع كذا يصير هنا بوش وهنا بول. اتمنى انها واضحه لانها سهله، واللي ما وضح له الفكره هذه معناها انه ما كان مركز معايا، لكن ما في مشكله لو طلبتوني اعيدها لا يمكن اعيدها. طيب بس مو الحين، خلونا ايش نمشي على اللي بعدها. اوكي طيب اللي بعدها اللينير موشن. ايش اللينير موشن؟ اللي هي الحركه، حركه الانسان عاديه. تمام، واحد يمشي كذا تك 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 فورورد، تك 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 باكورد. تمام، او يمشي سايد تو سايد، يمين يسار، او حركه الاسانسير هذه فوق تحت، هذه كلها لينير موشن. لينير موشن هذه ما لها دخل في الانجلر موشن. طب ايش يصير في اللينير موشن؟ وكيف ان الفيستيبولار سيستم يقدر انه يوضح للبرين انه والله قاعد يصير الشيء هذا. كيف؟ نطالع. الان عندنا هنا زي ما انتم شايفين اللي داخل الاوتوليث اورجن، هذا هو اللي قدامكم. وش اللي قدامنا؟ عندي بس في شغله هنا قدامي بابعدها عشان ارتاح منها. طيب هنا عندنا يا طوال الاعمار عندنا زي الجلي. تذكرون الجلي القديم هذاك اللي يرج؟ هذا هو. تمام تمام، زي الجلي. اوكي، داخل الجلي داخل ناشف فيه، داخل فيه اللي هو دقيقه باي ذا واي معاذ ام سوري I started speaking Arabic كذا تحمست فجاه. في احد عندنا non Arabic speaker؟
I'm not aware بس I think most of them يتكلمون عربي.
اي لاني
الأغلبية.
تحمست شوي معلش.
والله إذا في أحد is non-Arabic speaker please raise your hand. We'll
yeah,
see
there
if
is
there's
no just to make sure يعني انه I speak خلاص English، لكن اذا فيه يصير خلاص اكمل عربي انجليزي. طيب
اللي يريحك يا دكتور، واتوقع انه يمكن يكون اوضح للجميع انه يكون عربي يعني.
طيب ما في مشكله. طيب فهنا عندنا الان الجيلاتينس فلويد هذا او الممبرين هذا نفسه. تمام، فيه there is some hair cells as we can see here. طيب هنا hair cells، شعيرات هذه نشوفها inside. تمام، embedded inside here. So these hair cells are actually inside these gelatinous fluid، داخل مزروعة داخل الجل هذا. فوقها بالضبط لاصق فيها كريستالات نسميها الكريستالز. هم مكتوب هنا الاوتوليث. ايش معنى اوتوليث؟ هذه كلمة لاتينية من مقصد اللي هو الصخور، الحجار الصغيرة هذه. تمام، فهم شبهوها بالصخور ويسمونها برضو crystals. فthese are actually crystals، يعني انه اشياء لها احجام واوزان، يعني لها حجم، لها ثقلها. طيب طبعا صغيره مره very tiny thing. تمام، لانه اصلا الانر اير كامله او الفيستيبولار سيستم كامل يقول لك تقدر تغطيه براس اصبعك الصغيره. يعني عارفين قد ايش هو صغير الفيستيبولار سيستم كامل؟ فاذا كان هذا اصلا حجمه، فكيف راح يكون حجم الكريستالز هذه؟ لكن الاساس انها لها اوزان بحيث انها تضغط على
دكتور. Sorry to interrupt you, Dr. Faisal, but we're receiving comments that there are non-Arabic speaking attendants here. So if you can manage to.
Yes, I'm so sorry, my friend. Okay.
We also apologize for this. So
you
can continue. Sorry for you interrupting me.
No problem. So the problem here now is, or let me explain this again. Now, in the linear motion, in the otolith organ, we have this structure. Okay, so the gelatinous fluid, inside this gelatinous fluid, there are hair cells embedded inside, and these are some crystals are attached to it. Okay, so these are real crystals that have mass. Okay, so and weight. So these crystals, I mean, it's called otolith. It's a Latin verb or Latin word coming from Latino language, which what we call or what they mean by this is a rock or the rock. Okay, so here we have these rocks or these crystals are embedded or are attached to this gelatinous fluid, and there are inside the hair cells are embedded inside. So how does it really work? How does it really work? The main thing working here, or the main thing actually supporting this, is the gravity. Okay, the gravity. So let's imagine, guys, that this is the gelatinous fluid, and these are the crystals. So if someone going forward because of the gravity, these rocks will go down and will push. At the same time, when it's pushing here, because they're going forward, it's pulling in the other side, in the back. So there is a push here and a pull here. So that's meaning this patient is, or this person is moving forward. And when they're going backward, it's actually pushing in the back and pulling in the front. Okay? And if they are going side to side, it's going this way and it's going this way. So if it's going this way, there's a push here and a pull here. And if we're going in the other side, it's pushing here and pulling there. Right? So the angular motion and linear motion. Angular motion is when the fluid inside is pushing and pulling, okay? And the linear motion is when the crystal is pushing in one side and pulling in the other side. Before we move on, this physiology is very important, so I hope everyone has gotten it very well. Let's. I'm really interested to know if there is any question in the physiology part, Yama.
Physiology part.
So physiology part, if anyone has any issue with the physiology, the one I just explained, before we move on.
There is a question, what's the difference between the two fluids in the SCCS? For the SCC?
Yeah, well, the two fluids are different in their in the component, okay, of it. So because they both have a sodium and potassium, so the density of each of it is different between each other, okay, and these can be a cause of some pathologies that can be discussed later, or that you guys can look at it later, inshallah.
Okay, there's one question, I think, or two questions that have a similar idea. Can you repeat the push and pull for sideways linear motion?
Yeah, so the sideways linear motion. So imagine, guys, I'm going this side. So I have the crystals here. If I go to this side, it will be pushing into this side and pulling in this side. And if I go to the left, it's gonna push into this side and pulling in the other side. It's the same as if I go forward, it will be pushing forward and pulling backward. If I go backward, it would be pulling or pushing backward and pulling forward.
Okay. Question here, how do the proliferative lymphatic waves disrupt hair cells in the organ of the corti?
What is it again?
How do the pre-lymphatic or lymphatic waves distribute hair cells in the organ of corti?
ترى الصوت يقطع.
Okay, I'll try to repeat again. How do the pre-lymphatic waves disrupt hair cells?
Waves.
Yeah, pre-lymphatic waves disrupt hair cells.
Can
Spell it.
no, can you no I'm reading it now.
Yeah.
But can you elaborate more on their question?
I don't know if can the person who asked this question elaborate. As they try to elaborate on their question, can we move on to another question if that's okay with you?
Yes.
Okay.
Yes, of course.
What are the difference between angular motion and linear motion?
So angular motion again is a motion that has angles on it. So bending, flexion, extension, side bending, and rotation. So these are angular motion, okay? While the linear motion is moving forward and going backward, side to side, or up and down. Okay.
Yeah. Keep seeing the questions, or you want to move on?
If there is any other question.
Yes, there is regarding physiology. Well. So can the doctor repeat the oculic physiology?
Repeat the otolith physiology. The otolith physiology. طيب, as we said, let me close this. Okay. So the otolith physiology here. Now, as you guys can see here, now we have the gelatinous fluid and we have the hair cells embedded inside, and we have the rocks on the top of it attached to it. All right. So here what we have is if the gravity here is the main thing in this part. So if the patient, let's imagine that this patient here is moving forward to this side, okay? So if this patient moving this way, the crystals here, because it has weight and there is a gravity from bottom there, it will push to this side and pull in the back, okay? So by pushing here into these hair cells and pulling these hair cells in the back, the brain immediately would know that this patient is moving forward. However, if the same thing happening backward, so if the patient moving backward, what's going to happen here is this will be pushing in the back and it will be pulling in the front, where the brain would know immediately that this patient is moving backward. Same thing is happening when patient is moving side to side. So if you are moving to the right, the crystals will be here pushing to this right, and it will be pulling in the left, and vice versa also would be pushing in the left and pulling in the right. All right. Shall we?
It's up to you. Do you want to continue with the questions or move on? I believe moving on, Mavi.
Okay. Okay. طيب. I'm just so sorry. The mouse is okay. طيب. Now, when we have any pathology happening to the vestibular system, it can be either a functional impairment or mechanical impairment. And what do we mean by mechanical and functional? Now, if you have this vestibular system functionality affected, طيب, so if any disorder that linked to the vestibular system, either centrally or peripherally, what do we mean by central and peripheral? Central, or let's start with peripheral. Peripheral is anything or any disorder happening in the peripheral part of the vestibular system, تمام, until it gets to the pathway inside the brain, right? But if there is anything happening inside the brain, the vestibular pathways, there are vestibular pathways inside the brain. So if there is anything happening inside the brain, that's what we call central. So there are some central issues can affect the vestibular functionality, right? But at the end, these are both functionality. As I said earlier, that we have functionality in the both ears, okay? So, and there are same level of functionality, all right? So if any disorder happening either unilateral or bilateral, طيب, what's gonna happen is the functionality of this side will be affected. So the functionality, when the functionality is affected, the information that is going to the brain will be different. And there we will be experiencing some imbalance and some dizziness. So that's why, first of all, we need to know why this functionality is affected and to treat that cause. Then we move on to, once we treat that cause, we move on to know exactly if the functionality need to be regained or not. All right. So the mechanical problem of the vestibular system. Remember, guys, when I said that we have a crystals? So these crystals are in the otolith organ. However, the otolith organ, or the crystals in the otolith organs, sometimes can leave the otolith organ and go out to the semicircular canals. And if that happens, then this is something that we call a mechanical problem. Why it's mechanical? Because it's actually something left its place and went to another place, right? In this case, the treatment of that is some maneuvers that we will do is when we bring back these these crystals, we bring it back from the semicircular canals and we take it to the its place in the otolith organ, and we do this by repositioning maneuvers, okay, that we can do it in the clinic within a few minutes, right? All right, so let's move now. Just trying to share with you. I know we have a lot of information, and I know that we have also more information to know more, but this is an introduction, and we just want to get just an introductory kind of a taste to it, and inshallah, hopefully we can later on manage a workshop that we can do together بإذن الله تعالى. لكن هنا, here, what I want you to know is each patient that we see, we start with them subjectively. So we have to start with subjective examination, moving to medical screening, going to objective examination, and then reaching out to intervention and progression. And why we do this level? Because some patients are not our patients. Some patients are not supposed to be seen by us. So when we look at them subjectively, we can say either this patient is my patient or this patient is not my patient. And subjective examination is one of the most important parts of the examination. And you really have to be very detailed in here, especially with these kind of patients. Right? So if this patient, after you ask them subjectively and you find out that there are still in the area of your practice, you can move on to medical screening. And medical screening is when you use a validated examination to see if there is any risk or any red flags that you can see. If any, you can send this patient out, or if not, you can move on to the objective examination. All right. So some examination that we need to know subjectively, like the name, gender, history is very important. Who referred this patient to you, occupation, medical history of this patient, either past, present, or family history. Also, you need to know if, in the vestibular system disorders, if there's any dizziness, if this dizziness or this symptoms is less than 3 days, we call it acute. But if it's more than 3 days, we call it chronic. طيب. Now, in here, the main symptoms or the main sign that we're looking at is dizziness. We don't have pain. So remember when you deal with musculoskeletal patients that you ask this patient, how is your pain? Here, you don't ask patient about their pain. You ask their patient about their dizziness. How is your dizziness? Okay. So these dizziness can be either constant or spells. These dizziness can be positional or spontaneous, and they can have different duration, and they can either associate it with the auditory disorder or not. And by actually looking at this, and later on we can discuss some details about it, here where you can pick if there might be any issue with the central lesion or any issue peripherally that might be the cause of this problem. So remember, one person asked about the dizziness and what are the difference between dizziness. So dizziness is actually a general word. It's actually a vague word that we use. But there are some types of it. So there is this vertigo, which is a spinning sensation, a truly spinning sensation. It's either you are static or constant and the room around you is spinning, or the actual room is not moving and you are the one who's moving. So, but there is a truly spinning sensation, okay? The lightheadedness, also, the lightheadedness is something that we call like the pre-syncope. You are fainting, black, you don't remember anything, you lose your consciousness. طيب. If someone losing consciousness here, then this patient has nothing to do with the vestibular system. So consciousness or vestibular system will not make this patient or any patient losing consciousness. طيب. Disequilibrium is what we call imbalance. Asalapsia is when you see things unclear. I don't mean diplopia. Asalapsia is different than diplopia. So diplopia is when you see things double, you see things twice. Asalapsia is when you see things that are not clear. Here are some scale that we use. Medication is also something that we need to know subjectively, and some history of this patient about their social, their smoking or any other part. So also the medical screening will include things about the cervical instability of this patient, because you're dealing with the cervical a lot. If there is any VBI issue, if there is any central nervous system issue. So there are some different examination that we use to assure that if this patient is normal, or if this patient has a peripheral lesion, or this patient has a central lesion. If any suspicion about central lesion, we move on to the upper motor neuron test, just to assure if there is any upper motor neuron issues. Okay, the ISF, I'm sure that you guys are aware of it. I just want to take a quick visit to it. So the ICF is okay. I mean, as a rehabilitation people, it's very important to know the disease, but also what's important for us is to know actually what's impaired. So if a patient had a stroke, okay, good to know, but what happened after a stroke? What is the impairment? So if it's either a weakness in the upper limb, a weakness in the lower limb, difficulty speaking, anything. Okay, so once we know what are the impairment, we can know that what are the activities that patient cannot do. And because they cannot do these activities, what are the things that patient cannot participate in anymore? And also we need to know here what are the personal and environmental factors that is affecting that patient also. So we need to look at the patient as a whole patient. here some common vestibular disorders that you guys can read about. It's very common and it's very important to know. Um, Here is a very good actually paper about how to approach dizziness in emergency department, and it's very good, you guys, if you can have time to read. So the take home message here, that we have this I'm sorry, this this population, this population around us are um, actually experiencing a very frustrated feeling. They need someone to help them. We are a integrated team working together, from physician to audiologists to physical therapists to other specialties, to assure that this patient getting back to their life with the best quality ever, inshallah. Just assure that you are working very detailed in this patient and assuring that you have the right diagnosis so you can have the best treatment for this patient. I always believe first step of a proper treatment is a proper diagnosis. So here are some recommended resources that I would guys recommend to read. And these are websites that are very valuable and very beneficial. And here is my email and my Twitter account if you guys want to reach out asking any thing. Thank you guys so much. I'm sorry it's almost an hour and a half. We'll take maybe 5 to 10 minutes going through any question, Maad. Go ahead.
Okay. So one of the questions that we have here, in case of people who have postural hypotension, when they suddenly get out of place, they get dizzy. How do I differentiate between them and the problems of vestibular system, as they are they the same symptoms?
I was in mute. Well, there are differences between them. Uh, See, that's why subjectively you have to work hard sometimes with patient. However, I find it very easy sometimes. So you have first to know if these patients are actually at risk of this postural hypotension. One, two is you ask the patient if it's only having or experiencing this imbalance when you are having a prolonged sitting and going direct to standing, because if it's only in that position, if someone has a vestibular issues, they're gonna have it in different positions, not only in this movement. Okay, so that would help also.
How can I? There's a question. How can I differentiate between mechanical and functional impairments?
Well, mechanical, that's a good question. I'm sure people would ask it, but it's something that we cannot go through it a lot because of the time. But definitely there are symptoms. If you guys remember the again, I'll give you this presentation, and if you guys go to the common pathologies, the first pathology, the most common one, is the benign paroxysmal positional vertigo, is actually the BBVV, where the actual rocks are moving into the canals. So here there are a specific kind of feeling that the patient will experience, rather than if the patient have issues with the functionality.
Okay. Another question is, what is the difference between disequilibrium and lightheadedness or lightheaded?
It's different, very different. lightheadedness guys اللي هو إغماء, fainting, يغمى عليك, تفقد الوعي. This is lightheadedness. Okay, pre-syncope, you faint, you lose consciousness. Disequilibrium, you are awake, you know where you are, but you are imbalanced. تمام.
There's a lot of questions here, Doctor. I don't know where we will be able to cover them in 10 to 5 minutes. So I'll try to read as much as I can. And I apologize to anyone who put a question and has not been answered. You can contact the Dr. Faisal through his contacts, whether it's on Twitter or his email. Yeah, is that right?
مرحبا ألف في أي وقت.
He's always willing to help. Okay, so moving on.
Thousand welcome.
Yeah. يعطيك العافية. How can we deal with vestibular hypofunction patients who also have eye problems?
Well, we need to know what are the eye problem that we are talking about. Are they blind? Are they having just difficulties viewing things and they just need to be using glasses? It depends. It depends, to be honest with you.
Okay, this question has been repeated several times. What are the red flags, if there are any red flags?
والله شوف
or treating.
يعني as we said in the subjective examination, if we guys remember, we talked about constant spills, duration, things like that. So the main, I mean, there are different red flags actually, but the main one is what we call 5Ds and 3Ns. تمام. 5Ds اللي هي بسم الله الرحمن الرحيم drop attack, diplopia, dysarthria, dysphagia, drop attack. Okay, and 3Ns are nystagmus, numbness, and nausea. I think. I'm sorry, guys. I think that these are the 3Ns: numbness, nystagmus, and hopefully nausea. Yes. I'll look for it again. I'm sorry. I'm so sorry. You go ahead for other question, but I'll look for that.
Okay. Can I ask a question is, can I ask a patient to check for ear infection who had balance problems after RTA or TBI?
Well, definitely. يعني they have to be seen يعني first by the ENT doctor to check if there is any problem in the ear.
Okay. How to differentiate between dizziness due to ear or anemia?
طيب.
Or anemia.
The 5Ds, diplopia, as I said, dizziness, drop attack, dysarthria, dysphagia. Okay, and صح, nausea, numbness, nystagmus. Just to make sure. Yeah, go ahead.
Oh, okay. Just one question.
Anemia وايش يا معاذ؟
How to differentiate between dizziness due to the ear and anemia?
Well, anemic patients, again, it's something that's it happened. يعني you would so let me tell you this. You know, now we have the subjective examination, we have the medical screening, we have the objective examination. There are some findings that will lead you more toward going with the ear problem, and there are things that would take you more toward medical problem. Like, for example, one of the things that we might lead me to differentiate between this is the kind of feeling that the patient have. Now, some patients, they would say, I feel like I'm going to faint. عارف اللي خلاص احس اني بيغمى علي يطيح علي. This is like an anemic kind of feeling, انه احس اني بفقد الوعي. You know, balance or I mean vestibular issue, it won't give you this feeling. You are full awake, but you are imbalanced. عارف علي كيف? So that might be one of the things that I can use to differentiate, other than different things that I will be using definitely.
This is a question regarding stretching exercises. So if a patient has a problem in the vestibular system and has tightness or tightening of the neck muscles, can you do stretching exercises for the neck muscles, or maybe this might affect the patient?
سامحني, can you repeat
again? Okay, sorry.
Yeah.
I'm reading the question too fast, maybe. Okay, so if if a patient has a problem with the vestibular system and has a tightening or tightness in the neck muscles, can we do stretching exercises for those neck muscles, or maybe this might affect the patient in terms of their symptoms?
Well, depends, my friend. Now, if the patient, as again, يعني احنا we're looking at a whole patient together, صح? And we are experiencing different things. So let's start with things that is affecting the patient the most, and let's see how can we take this care into different level. So you might need to, depends, you might need to work on the neck before the vestibular system, or the vestibular system before you work on the neck. Yani it depends on the level of of severeness. And if there are some muscles that are very tight and neck problem that you can't actually do anything to the vestibular system until you take care of the muscle. عرفت علي كيف؟ يعني depends.
Here's a question. What's the best way to start it to treat a patient with vertigo using manipulation or different exercise options? I mean, like, can you do manipulations?
No, we don't do manipulation. We do.
What are the exercise options you can do for this patient?
We do repositioning maneuver. Okay, repositioning maneuver. Again, I'm very sorry, guys. I know it's only an hour and a half lecture. We're just giving an introduction. You know, the mechanical problem. Let me do this. The mechanical problem. Okay, it's being tested by a specific kind of test that we test the canals to see exactly where is this otolith organ went to, which canal. And if we found out, or if we find out in which canal, we can easily bring it back to its place by doing something we call repositioning maneuvers. Okay, we reposition the the otolith organ to go back to its place. هذا في الميكانيكال part. في الفانكشناليتي part, there are exercises that we are doing for the patient. We are relying on the VOR outputs, the one we discussed first. Okay, so we do some exercises to enhance the functionality of the vestibular system. Either it can be unilateral or bilateral, and you can upgrade it as you go with the need of this or for this patient. So maybe this will help.
I think we'll read 2 more questions, and then we'll probably end the sessions. Okay, so this question is written in Arabic, so I'll try my best to translate it. Okay, so when there is a child who has dizziness and loss of balance, but can ascend the stairs without support, I think. Is that an inner ear problem? A child who has dizziness and loss of balance can ascend the stairs, okay, by a slight touch of the back or clothing, but without additional support, like something to support themselves. Is this a vestibular problem? Could this be a vestibular problem?
Well, that's a balance issue.
Yeah.
Okay. And when we say balance issues, can be either neurological, vestibular issue, musculoskeletal, we don't know. So it's hard to say, actually.
This is another question, and I think this is the last question we'll ask. I apologize. There are so many questions. I think, again, I repeat, Dr. Faisal is willingly to answer your questions through his contact. So you can send your questions to him if we haven't answered your questions here. So the last question is, how can I know if dizziness is from the vestibular system or from the neck muscles?
Well, there is something that we call CGD, which is the cervicogenic dizziness. طيب cervicogenic dizziness is when you have a dizziness from the neck combined with the neck pain. طيب however the you cannot diagnose someone complaining of dizziness. I mean, you cannot say that this person is complaining of dizziness because of their neck unless you rule out all the other causes of dizziness. So you have to look for, and for example, there are people who are saying that whenever you see a patient complaining of a pain or a headache in this area, the occipital part, and a neck pain, this is a sign of a dizziness from the neck. You can't just say that easy. You have to go through specific kind of examination to assure that this patient is not experiencing something critical or something. Then after that, you can just say, after you move on and clear everything, and you lift up with this kind of symptoms, you might be relating this to neck problem. Hope I answered that question.
Thank you, Dr. Faisal, for everything. Thank you for your time. Thank you for this lovely presentation and lecture. We really enjoyed every single word that you told us, and we learned so much from this lecture. And I'm pretty sure that everybody in the audience learned a lot from you. Again, we apologize. I know you would love to give all of your time to answer people's questions and inquiries. However, looking at the time, we will have to cut this short, but I'm sure we'll probably have you another time to do some kind of a lecture again or a workshop probably soon enough, inshallah.
Please,
thank you for your time.
You're welcome. Thank you guys so much. Please, accept my apology. I know this is, it's very hard to discuss all this in 2 hours and to explain it very well, but I'm very happy to be reached out to answer any question, and hopefully we can manage something. We can do a 1 or 2 day workshop inshallah later on in the month. Thank you so much, guys. Thank you all.
Thank you for your time. Thank you, and thank you for everyone who attended. Have a nice evening.